We have Dr. Ian Carroll, who is an Associate Professor of Anesthesiology, Perioperative, and Pain Medicine. He is also the Chief of the Stanford CSF Leak Headache Program. He will be sharing with us some long-term epidural outcomes. Dr. Carroll.
Excellent, thank you. The disclosures I have are I won't show you any pictures of any brains. I will not show you any pictures of CSF venous fistulas. It's a sad, sad thing. Indispensable help came from the people here for the data I'm going to show you. Two of them are in the room, Dr. Shivink for helping me along this road at the beginning of starting to get interested in the leaks, and Dr. Callan, who helped me analyze all of this data. I'm going to show you and write it up and turn it into something informative instead of just a big mess. Thank you both. So between August of 2016 and November of 2018, we decided we wanted to understand when we were patching people who was getting better, who was not getting better. Was it really useful to patch people who had stories, clinical histories, and symptoms that suggested a CSF leak, but whose imaging was not always positive? Something that I thought early on was helping some people, but found was controversial within my institution and outside of my institution. And so at the urging of my chair, we started to do a quality assurance project to prospectively measure outcomes using validated metrics of the core symptoms of CSF leak, including a PROMIS global health metric. The PROMIS metrics are metrics that were developed with the support of the NIH. They have some unique properties. With a PROMIS metric, the US healthy norm is always 50, and a 10-point change is always a full standard deviation, which will make it a little easier for you to understand what those results mean when I show them to you. We use that as our quality of life metric. We use the HIT6 to measure headache severity. I wanted to capture all of the core symptoms of a CSF leak. So we had a metric for neck pain, nausea, tinnitus, and early on we were really very interested in the neurocognitive problems that patients with leaks often report. So we used a PROMIS metric for neurocognitive symptoms as well as one for fatigue. Patients could fill it out on their phone or on their computer browser. And we started measuring this before people got patches and then after each patch. This is what the cohort looked like in that time period from 2016 to 2018. There were 243 people who we assessed in clinic. A number of them actually got patches before they ever completed their first measure, so they weren't included. But we wound up with 85 patients who completed the full set of measures before their first patch, got at least one patch, and did a complete set of measures at least one time after getting patched. Of those 85 patients, this is kind of some of their background data. Mean age was 42 years. What I want to point out here is the average symptom duration of the 85 patients in this cohort is over 8 years. These were people who had been suffering for a long time. They had tried many, many therapies. It speaks to how long somebody can have symptoms before getting treated. 98% reported head pain, but you can see that, in fact, of the general symptoms, a very high percentage of people not only having head pain, but neck pain, tinnitus, fatigue. 95% of people reporting fatigue as a major symptom. Of those who had head pain, 85% reported that it was orthostatic, and we measured a variety of parameters of that orthostatic head pain. We think of orthostatic head pain as head pain that's postural, but what does that really mean? Is it defined by having worse head pain when you're upright, or by better head pain when you're flat? And how long should you be flat before you get head pain relief if you're going to think it's orthostatic? And so we were interested in this. We decided we would measure all of those. And this is how those metrics looked when we started before they got their first patch. So the mean PROMIS global physical health was 32. So remember that 50 is the norm for physical health in the US population, and 10 points is a full standard deviation. So these people who had been suffering for 8 years were 2 full standard deviations below the mean. They were extraordinarily compromised. They were in the 4th percentile of global physical health, metrics that are similar to people with advanced lung cancer and HIV. So this was not your patient who's working every day, who's doing all right, but has a little bit of a postural headache. These were people profoundly sick for a long, long time. You see that their headache impact test 6, their HIT-6 scores were in the severe range. Their PROMIS fatigue measurements, again, 50 would be a normal amount of fatigue, the US norm. 10 points is a standard deviation. They're a standard deviation and a half above the norm. They're in the 95th percentile for fatigue in the US population. That puts them right on par with the fatigue seen in people with significant multiple sclerosis. All right, so again, profoundly affected patients. Of those 85 patients, when we imaged them, this is data collected before we started doing any lateral decubitus imaging looking for CSF venous fistulas, so this predates our current understanding of CSF venous fistulas. 16 of the 85, or roughly 20%, meet ICH-D3 criteria. They either had a low opening pressure or they had a positive imaging study. 81% of these patients who are profoundly sick and reporting orthostatic headaches and have been sick for years, they have no positive imaging study and they have no low opening pressure. And the question is really, what should be done with those patients? So this is graphically breaking it down. We have 16 patients who are ICH-D3 positive, 69 who are ICH-D3 negative. In our hands, they then underwent an average of 3.6 patches, 3.6. And after that, these are the outcomes that we measured. So it's a lot of data here. I'm going to break it down for you a little bit. The first thing I'm going to point out is this is long-term data. So among these dramatically sick patients who've been sick for 8 years after patching, this is data that's collected after patching, a mean of 521 days after their first patch, over a year after their last patch. And what you see here is that their PROMIS physical health has significantly improved, highly statistically significant, and in fact, they have highly statistically significant improvement across a broad range of measures, including physical health, mental health, HIT-6, neck pain, fatigue. Nausea doesn't quite reach statistical significance. You have to ask yourself, are these statistically significant findings clinically meaningful? Well, for the global physical health PROMIS metric, there's a number of reports talking about what's a clinically meaningful change. Is the change enough that it makes a difference in the life of our patients? When we look at this, by whether they met ICH-D3 criteria or not, what we see is among the 16 patients, by the way, whose average symptom duration did not change from the ICH-D3 negative. Even the ones who met ICH-D3 criteria, having a low opening pressure or positive imaging, average duration 8 years. Of those 16 patients, 13 had a clinically meaningful response despite being symptomatic for 8 years. 3 did not. And that winds up being a 81% clinically meaningful response rate despite long-term symptoms. They did not have to have surgery to feel better. But what about the 81% of patients not conforming to ICH-D3 criteria? And I think in many ways these are the most interesting patients, not just because they are the most numerous. In our data, and also a prospective cohort collected by Hosoya in Japan from 11 hospitals, again, 80% of people who are collected for orthostatic headaches turned out to be, in fact, imaging negative. So it is my experience, the experience of the headache clinic, other centers, when prospectively evaluating patients with orthostatic headache, 3/4 to 4/5 will be imaging negative. Either we don't understand the major cause of orthostatic headaches, or our imaging is failing to detect clinically important leaks in a substantial proportion of patients. One of those two things, or a combination of those two things, is true. So what happened when, in fact, we offered patching to these patients? So we look at these 69 patients, again, an average of 3.6 patches, and this is the percentage that had clinically meaningful responses. So 37 of the 69, or 54% of these patients who were profoundly ill to start with, had been sick for 8 years, over a year after treatment, still have clinically meaningful improvements in global physical health. Now, that's a 54% response rate. The 54% response rate is clearly lower than the 81% response rate among those who are imaging positive. So if you want to maximize your success rate, only patch those people who are imaging positive. You will have higher results, you will feel good, almost everyone will do better. If you want to have a high patch rate and show good numbers, only patch those people who are imaging positive. But if you want to help the highest number of people who can clinically meaningfully benefit in a long-term way, don't do that. 73% of the clinically meaningful responders, 3/4 of the clinically meaningful responders, would never have received the treatment that resulted in long-term benefit if their patch had been contingent upon having positive imaging or a low opening pressure. So what can help us identify those patients who are most likely to have a clinically meaningful response among those who don't have positive imaging or don't have a low opening pressure? We looked at a variety of factors, and what I want to point out here is, number one, simply reporting I have postural head pain had no predictive ability. It did not predict who was going to be better a year later. If we look at time upright before the head pain started, again, no predictive ability. If we looked at migrainous symptoms, things that you might say, oh, they have migrainous symptoms, I'm not going to offer them a patch. Photophobia, phonophobia, nausea or vomiting, these had no negative predictive ability. Migrainous symptoms did not predict a lower likelihood of long-term clinically meaningful benefit. But what you do see here is that two domains of orthostatic features that are conceptually related and tied to each other had predictive ability for who was going to be better over a year after treatment. And that is, how low did your head pain get after being flat for an hour, and how low did your head pain get after being flat all night? How well you feel after being flat is giving us some idea among those who are imaging negative of who's going to have a long-term benefit with epidural patching. So let's look at that raw data. This is the data. What we have here on the, do I have a pointer? I don't know. It doesn't matter. On the y-axis, we have the improvement in the PROMIS physical health score. Again, 50. There you go. All right. So let's see. I don't know. It may take somebody smarter than me. So the important thing, I can do it. The important thing is, again, a change of 10 points on the y-axis is an improvement or a decrement, a worsening of a full standard deviation according to the US population. And what you see here is the blue dots are the people who had clinically meaningful responders. Recognize here that this is not a symmetric graph. We've had to have the amount that somebody can benefit be higher than the amount that somebody can worsen to show you, because in fact we had so many more people who were benefiting than who were doing worse. And what you see here is, if you look, here we have pre-patch headache severity on the x-axis. We've got the improvement in PROMIS physical on the y-axis. This is no change. These are the people, this is the line that if you're at this, you had no change from epidural patching. Every dot above this is somebody who improved over a year after being patched, and the black dots are the people who did worse. This is the line that reflects having improved more than a full standard deviation. And that's the line that reflects having worsened by more than a full standard deviation. You'll notice that the ratio of people who improved more than a full standard deviation outnumbers the people who worsened by the same amount by a ratio of 13 to 1, favoring treatment. 13 to 1. And if we look at the people who, before they got patched, reported that their head pain, when they stayed flat for an hour, got down to a 0 or a 1, 76% of those people had clinically meaningful improvement a year out. Highly predictive. And that is strong evidence that the effect that we're measuring is not placebo effect, it's not regression to the mean, it's not natural history of the disease. How much better people's head pain gets when they stay flat after 8 years of symptoms that are completely debilitating predicts long-term clinically meaningful response over a year after treatment. So it's hard to explain that statistically significant relationship by nonspecific things. Among patients with chronic disabling symptoms suggesting CSF leak in whom imaging does not confirm a leak, 54% of patients show clinically meaningful improvement at long-term follow-up after an average of 3.6 patches. 2 factors specifically associated with CSF leak: more complete resolution of head pain upon being flat for an hour or overnight, significantly predicted the likelihood of being a clinically meaningful responder in global physical health. And most of the patients who experienced clinically meaningful improvement at long-term follow-up came from the ICHD3, i.e. imaging negative group, by a ratio of 3 to 1. There was, however, a higher rate of response seen among those who are ICHD3 positive. So think about what your goal is: high rate of response versus helping the most people. And just how safely can you do this? If you can do this very safely, then it would seem to weigh in favor of offering this to people who are ICHD3 negative. My data failed to show evidence of harm in offering those patients patching. People did better by a ratio of 13 to 1 than worsening. Thank you.